Hello friends, today I'm going to show a very complicated macular TRD case. As you see on the picture, it's 360-degree membrane from posterior pole to the periphery, very ischemic retina, and there is really no separation of membrane from the retina. There is no cleavage where you can just go inside and separate the vitreous from the retina. It's completely plastered throughout the retina. These cases are very tricky. Vision will be relatively better because there's not much detachment. In this case, vision was little less because of the ischemic retina. But then again, there is a detachment, and then if you don't operate, these patients are going to go blind. Very tricky case again. Unless you manage it proper way, it's going to cause a lot of redetachment, a lot of bleeding. I would like to share my technique in this, and then in the whole surgery, what I have done, I have used only cutter. I didn't use Caesar. I didn't use anything else. I didn't do bimanual. Again, I'm not trying to boast that you should do like that. But what I'm trying to say that you can make a maximum use of cutter in this kind of cases. One extra thing which I did in this case is to do visco dissection, which I'll show you. But then other than that, everything I could manage these cases with the cutter. Again, I'm not saying that you manage everything with a cutter. At any point of time you feel you want to change to bimanual, you should do that. But then this case I could manage with the cutter alone. Now I am just trying to pull the membrane from the disc. That is the safest area where you can't create detachment. There are a lot of people feel that when you pull the membrane from the disc, the chance of bleeding is there. Yes, it is there. So what I do is I raise the bottle height to 80. Immediately before I try to peel the membrane, I give tranexamic acid, keep the BP under control. That keeps the bleeding from the disc under control. So you can see there is not much blood. I could do visco dissection, and once the visco dissection is done, I can go ahead and do membrane delamination, segmentation, and delamination. So I am segmenting right now after delamination, and once you make the segmentation, things become better, things become easier. So that's what I'm trying to say. So use tranexamic acid, increase the bottle height whenever you feel that chance of bleeding is there, and then anytime if you feel that bleeding is happening too much, you can always do laser diathermy if you require. So after doing this, I'm trying to segment the membrane. Now you can see the vitreous is very sticky, very adherent to the retina, and you have to be very careful when you're trying to peel vitreous from the retina. Don't pull too much. You pull enough just so that you get small cleavage from the retina and membrane. And once you get the cleavage, you start cutting it. Don't try to pull too much. The moment you try to pull too much, you'll have big, large retinotomy. And once you have large, big retinotomy, it will keep creating more retinotomy because retina will get detached. And once it is getting detached, you will not get counter traction to hold the retina in place when you're trying to lift this membrane. So be very careful, be very gentle when you're trying to lift this vitreous from the this thing. There are a lot of attachments are there between these membranes, fibrovascular proliferation, and the retina. So whenever you feel there are attachments are there, you should cut it with the cutter. Once the attachments are removed, you should peel it with the cutter again. This method has to be very gentle, careful, and it has to be visualized properly where there is a strong adhesion is there. If there are strong adhesion is there, carefully trimming the adhesion with the cutter is the way. And once the adhesions are removed, once the attachments are removed, you can do the pulling part and then separating vitreous from the retina. So now you can see the almost three-fourth of the membranes we have removed, and you can see these membranes are not limited only to posterior pole. It is there up to equator, maybe beyond equator. So very tricky to do membrane peeling when the membranes are not in the posterior pole alone, but then they are in periphery. Because the visualization becomes poor, the handling will become very difficult when membranes are there in the periphery. So be very careful. Your visualization should be good. I have a gift of having 3D visualization with me, which really helps me to illuminate periphery of retina also fantastically well. At the same time, it gives me very good width or wide view when I do this membrane dissection in periphery. So 3D visualization does help me in dealing with this kind of complicated cases, macular TRD, and a slightest illumination brightens up the whole fundus fantastically well. So when you have good brightness, good illumination, good visualization, your handling of tissue, especially these fine tissue membranes, and then between the membranes and retina becomes very very important. So visualization is very important. Again, I because of this 3D visualization I have, it helps me a lot when I do surgery like this, mainly because of this diabetic macular TRD and membranes and also. Yeah. So this is what I want to say, that cutter is useful. How you use it is very important. Don't limit yourself to do surgery with a cutter alone. Don't keep that kind of ego. I never do that. But I could manage this case as far as possible with a cutter alone. Maybe I thought it is better when I try to do bimanual membrane peeling in this kind of case where the retina is not detached. What happens when I try to hold this membrane, try to cut with a scissor? Sometimes I'll create detachment. But when I'm trying to do this surgery with a cutter alone, without lifting much, I'm able to dissect, separate, cut the membrane, everything with the cutter alone. So this is advantage. Again, this is a 20,000 cut rate cutter. Again, there is a angle to the cutter which helps in doing membrane peeling very close to the retina. You can see I'm very close to the retina without creating any break into the retina. So does this these 20,000 cuts with the slanting edge, it does help. Once all the membranes are removed, when there's not much bleeding, we can confirm whether any immature membranes are there. And once you find immature membrane, try to remove it. And immature membranes are removed, everything is done. We'll try to do fluid exchange. Main aim is to do ILM peeling. So whenever this kind of complicated macular TRDs are there, my aim is to do ILM peeling also, because these maculas are puckered, damaged, and they are stiff because of this chronic detachment. So whenever possible, I try to do ILM peeling. And when I'm staining with the blue, the same time I would like to do base dissection also. Base dissection helps me lesser chance of bleeding once I do silicone oil removal. And ILM peeling helps me to what do you say, flatten the macula early as possible. That is my aim, and then giving the best visual acuity to the patient. Island peeling in this macular TRD patient and diabetic patient is very tough. Why it is tough? They are very adherent. They are very sticky. And again, in this patient, you can see the retina is elevated. In retina, elevated retina, when you try to do island peeling, the retina also goes along with the forceps. So it's very, very tricky. You are always scared that you're pulling the retina. You might create tear in the retina at the posterior pole, very close to the fovea, which is risky. So you're always very careful when you try to do iron peeling these diabetic cases. But then once you do it, patient gets good results. So I always try to do it. It is tricky. It is very skillful thing. Not everybody may be able to successfully do it, but then as far as possible, you should try it. Once it is done, everything is done, ILM peeling is done, base dissection is done, do a fluid exchange, try to drain the subretinal fluid, create small diathermy and create a small retinotomy so that I can drain the subretinal fluid, so that retina gets flattened faster, patient can get better visual recovery faster. You may not do it, but then when you don't do it, it's a chronic detachment, so it takes very long time for retina to flatten, and then you will be always doubtful whether retina will get flattened or not under oil. So I prefer to flatten the retina on table as far as possible, and then leave it rest to the oil and positioning. So this is what about this surgery I thought I should share with you. Thank you very much.